Hello, everybody. Welcome to our Sedation and Analgesia chapter of the On Call program of Neurocritical Care. I'm actually honored to talk about this chapter on behalf of our author group. So this has been a nice collaboration from many different experts in the field. So to actually give you some background information, we all know that providing analgesia and sedation is very important in neurocritically ill patients, and having appropriate strategies in mind and in place will be actually really helpful to minimize over-sedation and under-sedation in this setting. Let's focus on sedation first, and then we'll talk about pain management and analgesia. So I think just like anything else in critical care, when we talk about sedation in our patients specifically, we have to think about why are we doing this? You know, what is the purpose of providing sedation for our patients? So what I would like you guys to focus on is two actually main concepts. So the first is just like all, critical care patients, we're trying to provide comfort and making sure that they're safe. But then for our patients specifically, they may get sedative agents for specific indications such as high ICP management, or seizures and status epilepticus, which we'll talk about. And also for patients who are getting TTM or targeted temperature management, a lot of them are at high risk of shivering, and providing sedation could potentially help with shivering, and that is something that we'll also talk about. So, let's again focus on sedation for comfort and safety first. So again, just like anything in critical care, the idea is that why are we giving them sedation? If we're trying to make them comfortable, do we know the reason why they're uncomfortable? Before just giving a sedation, assessing the patient, making sure it's not the constipation that is making them uncomfortable. It's not, the infection that is making them uncomfortable. So after all of that has been assessed and treated, then, we can think about the sedative agent that is ideal in this setting. There has been a lot of randomized controlled trials that talk about lowest level of sedation to maintain comfort and safety. So we know that deep levels of sedation can be associated with worse outcomes, including longer length of stay, and also complications and overall lower rates of survival. And then also, as a result of this, it makes sense to have protocol-based pharmacological treatment plans that can actually utilize lowest level of sedation titrated per goals that we're going to talk about to help with achieving actually the safest and the potentially lowest level of sedation that is going to be effective for these patients. I think this brings us to the discussion of goals and what sedation goals we're titrating these medications when it comes to comfort and safety. Remember, I'm not talking about specific indications such as seizures or ICP management yet. So if it's just for comfort, meaning, if somebody was intubated recently and they're very uncomfortable and the goal is to make sure they're safe, they're comfortable, we're giving them a low dose or a continuous infusion low dose of sedation of some sort. The goal is or even boluses, which may be even more appropriate, to provide the lowest level of sedation. The idea is that to target specific goals, which include RASS goal or SAS goal. We know that RASS is Ridgemont Agitation Sedation Scale, and SAS is Sedation Agitation Scale. Usually, and for comfort, general comfort, the idea is we talk about this minimal level of sedation. RASS of 0 to -1 seem to be what we're usually targeting for, and SAS of 3 to 4 is what we're usually targeting for. And again, there's nice tables and charts for our audience to look at on the Neurocritical Care website. But let's say we have figured this out, we have a goal in mind, and we know that we're targeting for comfort and, lowest level of sedation. How are we going to go about choosing our medication? As of now that we're talking about this, there is really no specific medication that I can say has been clearly shown to be superior to other agents when it comes to sedative agents. So what I would like you guys to think about is your medication factors and your patient factors. So when it comes to medication factors, pharmacology, pharmacokinetics, meaning, what is the onset of action of the agent that I want to use? And do I want it to be fast? Do I not care about that? The half-life of the drug, meaning how long it lasts in the system. Do I care about the drug being cleared fast, or it's okay if there is some residual effects or there is prolonged effects because, let's say, somebody had chronic, for example, pain, that we're trying to use something that may be okay to stay in the system for a longer duration, which we'll talk about more about when we talk about analgesia. And then patient factors, what is their renal function like? What is their hepatic function like? What are the other comorbidities that may have that we need to know before choosing the right agent for them? Now, all of those are important, but remember that there's no one agent that is superior, but there are agents that may work better for a specific patient population. As a general rule, benzodiazepines have been shown to prolong intubation days and length of stay, and there may be potentially higher rates of delirium associated with them. But we know that even in general critical care, propofol and dexmedetomidine may be better agents. So speaking of these two agents as our potentially preferred sedatives, let's focus on these two agents. So dexmedetomidine, or Precedex, most commonly known as Precedex, the brand name, it's a centrally acting alpha-2 agonist. A PO version of this drug is clonidine, which people may be more familiar with or they may have heard of before. So when it comes to dexmedetomidine, the nice thing about this agent is that it does not cause respiratory depression, which is nice, meaning that you could extubate patients on this drug. You can use it in people that have never been intubated. And also, because it has a short duration of action, and because of the fact that it does not cause deep level of sedation, you could potentially do serial neuroexam on this agent. Now, it can be associated with bradycardia and hypotension, so its use may be limited by its side effects to hemodynamic instability. And also, one thing that is super important to note with this agent is that it does not change ICP. So if somebody has ICP issues, this is not a drug to use. As we're talking about, this is for general comfort. And people who may have some sort of discomfort because of the tube in their mouth or other reasons. And also, this drug actually, because it does not provide deep level of sedation, is not a drug that you're going to be using for people that may be paralyzed in the unit or people that really need deep levels of sedation. So things to think about. It does not have any anti-seizure activity. So again, something to think about. If that is something that people are trying to treat, also, this is not the agent of choice. Now, going to propofol, which is another agent that we talked about, that it could be, an attractive agent in our patient population. A very different mechanism of action. This drug is a GABA agonist with actually some sodium blocking effects, meaning that this can be helpful not only for sedation and general comfort, but it is effective for seizure management. Also, it can reduce cerebral oxygen demand, or metabolic demand. So basically, this could be helpful for people with high ICP or intracranial pressure. It does cause significant respiratory depression. So this is a drug that your patient has to be intubated if you're using it. It does have hemodynamic side effects, meaning bradycardia and hypotension. And if it's used in high doses for prolonged duration, it can cause propofol-related infusion syndrome, or PRIS, which really is evident by rhabdomyolysis, metabolic acidosis, renal failure, and basically cardiac arrhythmias. And the recommendation is that if you have a patient who's getting high doses of propofol for prolonged duration, which actually can happen, let's say if somebody has status epilepticus, and that's the reason you're using it for, or if somebody has ICPs that you're using a lot higher doses than you'll be using for your general sedation. The idea is that this drug could be associated with propofol-related infusion syndrome, and to prevent that, what you need to do is you need to check your CK, you need to check your lactate, you need to check your triglycerides to make sure that you are at least on top of monitoring of your patient and the side effects associated with propofol. Now, what about other agents? We can go back to the benzodiazepines. Again, as we talked about this, benzodiazepines are basically associated with longer ICU stay and basically intubation days. And also there is some evidence that the incidence of delirium may be higher. So where can we use them more effectively? When it comes to status epilepticus, as you all know, this is a drug of choice. There is different agents in this big class. We talk about midazolam, we talk about diazepam, we talk about lorazepam. Again, they're all GABA agonists, so they all could be used for status epilepticus, and they could also be used potentially to some degree for ICP management. They can reduce the cerebral metabolic demand, but not to the degree of propofol, so their impact on ICP is less than propofol or barbiturates, which we'll talk about. Now, when it comes to using or choosing the right agent, we always get questions, okay, which benzodiazepine should I use? When it comes to maybe one bolus dose for general comfort, again, let's say somebody's going to MRI, they need a small dose, probably doesn't matter much. But when it comes to, let's say, managing somebody's status epilepticus or ICP, then it does matter, because your lorazepam and your diazepam, the IV formulations are in propylene glycol, and having those, formulations on for prolonged duration could potentially cause the propylene glycol toxicity, which again is basically evident by hypotension, metabolic acidosis, high anion gap metabolic acidosis, renal failure, and to some degree people could seize because of this, and they're going to be very hyperosmolar. In that case, midazolam, because it doesn't have the propylene glycol, is the most appropriate agent. This is the agent that probably makes the most sense to have it on for a prolonged duration, but it doesn't obviously, it is not without any side effects. Clinical pearls about midazolam. One thing is that it has an active metabolite that can accumulate in renal failure, so that's just something to keep in mind. In patients with renal failure, the effects could be more prolonged. Also, it is hepatically metabolized, so unlike lorazepam, if somebody has hepatic failure, midazolam metabolism will be affected by that. All of them as a class can cause hemodynamic instability, so all of them can do that. Unique about midazolam is that it's a substrate of CYP3A4, so if you have drugs that are inducing or inhibiting CYP3A4, this is something to keep in mind. This drug could be subtherapeutic or super therapeutic, depending on what agents you have on board as far as drug-drug interactions go. So again, I think as a general rule, important to keep in mind that all benzodiazepines can treat your seizures and they could mildly affect your ICP, but midazolam may be the safest option when it comes to prolonged infusion, but as we talked about, some side effects should be taken into account. One big piece of information, just like what we talk about propofol, the dosing that you're using for sedation for comfort is much less than the doses you're using for your status epilepticus patient. Very different. So let's say where 0.5 milligrams of IV midazolam may be totally fine for somebody going to MRI, when you're talking about status epilepticus, the dose could be as high as 2 mg per kg per hour for somebody in status epilepticus. And bolus doses are almost always needed in patients that are getting it for status epilepticus. What about other agents? Let's talk about barbiturates as a class. The ones that we see being used in our population are Pentobarb, pentobarbital, and phenobarbital. Pentobarbital is the one that is used mostly for ICP management. they're not usually used, these agents, for sedation alone, just for comfort. Pentobarb is used, it's a GABA agonist. It's used for ICP management. It could be used obviously for status epilepticus as well. The idea is that it's used for ICP management because it can really put the brain in the coma state where it doesn't really require a whole lot. It doesn't require a lot of oxygen, doesn't require a lot of blood flow. So it kind of slows down things so that the metabolic demand of the brain is much less. And this way it can reduce the ICP. What are some of the issues with Pentobarb? Hemodynamic instability, obviously. There is a lot of drug-drug interactions. Barbiturates as a whole, they are CYP3A4 inducers. Other side effects with all barbiturates including phenobarb, include GI dysmotility, high risk of infection because of modulation of the immune system, and Pentobarbs, and phenobarb, again, they're both CYP inducers, just something to keep in mind. Now, one actually piece of advice about Pentobarb, and sometimes we get this question in our unit, is that, do I need to send for levels when somebody is getting that? The answer is that, it depends, and we'll talk about that. If you are using pentobarbital for ICP management, or if you're using pentobarbital for status epilepticus management, during the active phase of treatment, no, because by the time you get the level back, it's probably too late to act on that. And I have to say that your levels, your Pentobarb level and your EEG may not really correlate. So if you're treating somebody for status epilepticus, your best probably target to look at is your EEG. If you are looking at, Pentobarb for your ICP management, obviously looking at your ICP and clinical presentation of the patient is probably the best way to look at it. Sometimes making sure the patient's burst suppressed is also helping in that setting. The levels may be helpful though if, let's say, your patient's out of Pentobarb coma, but they're still not waking up, and you want to see if they're not waking up because of some sort of neurologic pathology, or they're not waking up because of the drug residuals and the effects that are still in the system. In that case, I think it's totally appropriate to get a level and see if the level's still really high, or if the level should be, if the level is low, meaning the drug should be out of the system by then. And the reason the patient's not waking up, it's because of their brain injury and not really the drug. So I think in that case, it makes sense. Phenobarb, again, another barbiturate, a lot of the same side effects, the drug-drug interaction concerns, just like Pentobarb. It is probably more so used for status epilepticus than just general comfort or, ICP management. Is a long half-life, so just something to keep in mind. People may not basically recover from the sedation effects of the drug as quickly, just because of the lingering effects and the long half-life of the drug. Again, if it's, seizure management, looking at EEG is the best idea for managing seizures, but sometimes it is helpful to check the level to make sure patients are not very subtherapeutic if they're not responding, or if, your patient's not waking up, or if there is a lot of side effects with the drug, to make sure that the drug is not toxic. So in those cases, I think sending for level would make sense. Last agent in this group to talk about is ketamine. Ketamine is an interesting drug. Ketamine is an NMDA antagonist. I think it is helpful for providing sedation, small dose if the sedation piece is needed. It also can have analgesia effects, so pain management, something that is going to happen with lower doses. In status epilepticus, much higher doses are used. We see these days case reports of using 10 mg per kg per hour of ketamine for status epilepticus management. And one clinical pearl, especially important for our patient population, is that there was some, I think, prior studies showing and looking at higher ICPs in people that receive ketamine, but there's newer studies saying that actually this may not be the case these days. So it's just something to keep in mind, that I think the idea of ketamine causing high ICP is not potentially correct anymore, and there's probably more evidence needed to really make that final conclusion on that discussion. As far as, side effects, or important clinical pearls is that it doesn't cause respiratory depression. If anything, it may be helpful for bronchospasms. It's just something to keep in mind. It doesn't cause a lot of the hemodynamic instability, meaning hypertension or bradycardia that we see with other agents. So it can potentially help with people coming off of vasoactive agents. It is more, it is causing more hypertension than hypotension. And then hallucinations may be something to discuss also, that maybe in people that are, significantly ill and they are in status or they are very sick, this may not be a big concern, but in patients that are getting it for, small duration or short duration or just for sedation or pain, this is something to obviously think about. Small doses of benzos have been used to technically take care of the hallucinations. One, I think, also really important piece of information is ketamine is that because of its mechanism of action and inhibiting the muscarinic receptors, it could potentially cause pupil dilation. So that's just important to know that this drug can cause that. So if, there's concern about herniation syndrome, look into the medications your patient getting. Additional imaging may not be needed because this could be just a drug side effect and not really a herniation syndrome causing the pupil dilation or blown pupils. So to kind of review this a little bit more, we talk about all these agents. We talk about the fact that they could potentially be used for sedation just for comfort. Some of them may be, more appropriate for specific indications. So let's review this one more time. ICP management, propofol is an agent that is mostly used in this setting. Barbiturates could be used, Pentobarb specifically. Benzodiazepines to a lower degree can reduce ICP. Seizure control, we talked about benzodiazepines, we talked about barbiturates. Propofol is an agent. Ketamine is also another agent with a different mechanism of action that could be utilized. And then in patients that are shivering as a result of TTM, there has been some evidence now showing that dexmedetomidine may be helpful by reducing the shivering threshold. So that's important to keep in mind. We didn't talk about the 3 indications I'm going to talk about now, but in the neuro ICU, we've had situations, as you all may have encountered, that people have paroxysmal sympathetic hyperactivity. I don't think the actual pathophys is fully understood, but what we think is that basically the sympathetic nervous system is overreacting and the parasympathetic nervous system is kind of suppressed because of the brain injury. And in those cases, opioids and sedatives have been shown to be effective, and opioids is something that we've used mostly. As far as other indications go that are unique in our patients, central neurogenic hyperventilation, which again, a pretty unique, I think, syndrome, not fully probably understood, not metabolic or cardiopulmonary related, but because of the brain injury, there is this hyperventilation that leads to basically alkalosis and technically hypocarbia. In those cases, usually multiple sedative agents are needed to kind of retain more CO2 and hopefully take care of this process. And then acute respiratory distress syndrome that is not unique to neuro-IC patients. A lot of other IC patients may have that, a pretty significant and, a severe condition. And in those cases, high levels of sedation are usually needed. Now, moving forward, talking about analgesia and pain management, I think it's fair to say that pain has always has to be assessed before moving on to agitation and delirium treatment. Pain is really the fundamental piece of this pain, agitation, delirium, thinking process that, if the pain is not treated adequately, agitation can happen and potentially can cause delirium. So it's just something to keep in mind. And in our patient population specifically, our people have many risk factors or many reasons to be in pain. People that come in with trauma, people that go under procedures, people that have neuropathy, people that, have intracranial hemorrhage, different types, subarachnoid hemorrhage, and different types of pain. Although it's probably difficult to assess pain in critically ill patients, there are, again, goals and parameters to look at. One assessment tool is the critical care pain observation tool that is also useful for intubated people, and then the behavioral pain scale. One also tool that is probably more unique to our patients and then people with coma that are recovering from coma is the nociception coma scale. That they look at motor factors, visual factors, verbal factors, and also facial expression. And the higher the number, the higher the degree of pain, which is helpful to look at and to use that in our patients that are recovering from coma. But let's say, we are using these scales and we're deciding that the patient requires pain management and, analgesics. So what are the options? I think it's fair to talk about opioids, although it can have side effects, which we'll talk about. It can potentially cloud a neuroexam, but it's still one of the primary pharmacological interventions for treating pain. So fentanyl is the number one agent that comes to mind. It's pretty accessible in different, regions. It is a pretty clean drug. It doesn't accumulate in renal failure. There may be some accumulation in hepatic failure, but still pretty quick onset, 1 or 2 minutes. Half-life is short unless it's been infusing for a few hours, just something to keep in mind. What we call this the context-sensitive half-life, meaning that, the half-life is short if it's just one injection, but let's say if you've had somebody who's been on a continuous infusion of fentanyl for 24 hours, the half-life is not going to be that short, and just shutting it off right before examining the patient when you're rounding is not going to be enough time to let this drug clear. The next agent we talk about and we probably utilize the most, it's Dilaudid or hydromorphone. Hydromorphone is a nice agent, I think, for patients without hepatic or renal impairment because there is risk with accumulation in both patient populations. And what I think is probably really helpful, where it is useful or where I think it could be helpful, is in patients with chronic pain that, they've had baseline pain and you need something that is a little bit longer acting than your fentanyl, then hydromorphone may be the right agent. But again, it comes with this lingering effect, which may not be ideal in patients with renal failure or people that you need to do quick serial neuro exams. And just something to keep in mind that, if it's something that we're okay with and we're okay with, doing. Morphine is another agent. I think probably out of all the three agents that I talked about so far, the fentanyl, Dilaudid, and morphine is the least favorite in our setting, just because of the fact that it has an active metabolite that can accumulate in renal failure. It does have a lot of hemodynamic instability. It is the one that is with the highest degree of histamine release, and so all of those factors will probably make it the least ideal of all the agents we talked about. Two other agents that I think not probably as commonly used, but it's worth mentioning, is remifentanil and Sufentanil. They are, as you can imagine, a derivatives of fentanyl. Remifentanil is that drug that is unique in the sense that very short acting, does not require renal or hepatic metabolism. So it is a clean drug. It is metabolized in the plasma by an enzyme. So, you give it, it's cleared, and it's pretty quick on and off. In the neuro OR or neuro procedures that are happening in the OR, this has gained a lot of, I think, attention because people are comfortable putting the patient on this drug during the procedure, and they turn it off, and the patient's waking up nicely, no issues. Sufentanil is a drug that actually is very potent. It's almost 10 times more potent than fentanyl. There is some evidence that it could be useful, especially in people that require a large or higher doses of opioids. But again, I think there's still some room to gain more knowledge about the utility of these two agents. They're obviously more expensive than all the other agents, so also this is something to keep in mind. Lastly, I think it's important to note that all opioids as a class, they could potentially cause some ICP increase, because remember that they can retain CO2, and CO2 can cause vasodilation, and because of that, there may be more blood flow to the brain, and this can be associated with higher ICPs, just something to keep in mind. Lastly, something to mention about fentanyl is that we know that fentanyl can potentially cause chest wall rigidity, and that could potentially also cause ICP, increase. And if that is the case and that is suspected in a patient, then it means that this is not the right agent for that patient to be used for. Lastly, I think there's a lot of discussion about using non-opioids because, we want our patients to get the minimal, sedating agents, especially when it comes to analgesia. So one option is acetaminophen, and with the availability of IV acetaminophen, there's a lot of interest in that. So although there has been some evidence that IV acetaminophen could be opioid sparing, there is actually craniotomy procedure studies that are published, and they have not been able to show that it is opioid sparing. So again, I think we're still learning about IV acetaminophen in our setting, but it's interesting to see, what the future of this drug in our patient population is. And then lastly, I think gabapentin is getting a lot of attention, and there's some evidence for its use and utility in patients with subarachnoid hemorrhage with that kind of headache pain, that this is going to be really helpful. So with that, I think we are done with the sedation and analgesia and neurocritical care chapter, and I hope that you guys learned something new. Thank you very much.